So I think, yes, since we have lots of options in the implant-based reconstruction, we've heard about some of those, and now Tassos Tsekouras, which is a plastic surgeon working both in Athens and London, will actually give us an insight about the pros and cons of each available option. And I think eventually we're going to get an algorithm about what to use and when to use it. Tassos.
Well, thank you, Sophocles. It's very nice to be among all these very important people. I would like to thank the organizing committee of the society, that the presidents, yourselves, for the kind invitation. I will try to share my screen, and can you see my presentation?
We can.
You can?
Yes, we can, but
okay.
Thank you.
Now, is it okay?
Yes, it is fine.
Okay, thank you very much. So I'm here today to answer some very debatable questions, and I'm not sure if I will make it, but at least I will. Hopefully, I will try, to raise the discussion. First of all, I declare that I have no potential conflict of interest with my presentation. A large percentage of women affected by breast cancer will undergo a mastectomy. Following a mastectomy, women can choose from many breast reconstruction options and achieve a natural fill with appropriate size and shape of the breast according to individual needs. These reconstruction options are also available for the increasing number of women at high risk of developing hereditary breast cancer who undergo risk-reducing mastectomy. In 2017, statistics compiled by the American Society of Plastic Surgeons have demonstrated that out of more than 100,000 breast reconstructions, nearly 87,000 were performed with prosthetic devices. The reasons for that is, of course, patient preference, improved mastectomy and reconstructive techniques, as we hear all day today, which they lead to improved outcomes. Patients and surgeons no longer find it acceptable to reconstruct just a breast mount. Current expectations are to reconstruct a breast that is naturally contoured and positioned and that provides optimal symmetry. This paradigm shift is multifactorial and related to lifestyle choices, to less invasive operations, to a more rapid recovery, and to the ability to deliver excellent aesthetic outcomes. It can be stated that reconstructive breast surgery is now an aesthetic operation. Prosthetic devices for breast reconstruction were first introduced in 1962 and have undergone significant modifications over the past 6 decades. Current devices can be filled with silicone or silicone gel, can be smooth or textured in surface, they can have a round or anatomical shape, and they can be of fixed or variable volume. The core studies have demonstrated that these devices are safe and effective with follow-up that ranges from 6 to 10 years. Inherited trade-offs must be weighted when choosing the ideal cohesive implant for breast reconstruction. So let's see what can influence our decision. The lenses through which to assess implant values are, of course, their characteristics. As we said, cohesivity, shape, texture, the surgical techniques, and the technological innovations that we see the recent years, and also, of course, will influence by the visual aesthetics and the dynamic response to changes in body position and tactile feel, of course, taking into account the complication profile of the implant-based breast reconstruction with silicone gel implants is the most commonly performed reconstructive breast procedure worldwide. Silicone implants are generally preferred over saline implants because of their more natural look and feel. Both saline and silicone implants are safe and effective, although silicone implants are associated with high patient satisfaction. So I think this question is more or less answered. Current silicone gel implants are made with highly cohesive silicone gel. The level of cohesivity, it varies greatly between styles. The cohesive gel results in less rippling and wrinkling. Although both fourth and fifth generation gels have a lower degree of molecular cross-linking and hence cohesivity than fourth generation gels have a lower degree than fifth generation products. The Despite that, the drawback of highly cohesive gels is that they have a less natural feel. Regarding the visual aesthetics of the final breast shape, round implants are believed to achieve a fuller or more convex upper pole appearance and are thought to be ideal for patients receiving a primary accommodation who have a good skin envelope. On the contrary, anatomical implants can maintain the natural contour profile of the device. As we said, they can have less rippling and wriggling. They tend to increase projection along the lower pole of the breast to provide a gradual slope of the upper pole, creating a natural breast shape. And of course, you must realize that anatomical implants are texture implants in order to lessen the risk of malposition. We'll explain this a little later. In general, anatomical implants are useful when maximal control of the breast shape is necessary, such as in patients with upper pole deficiency or a long torso. Round implants are softer than shape devices and tend to move more like a natural breast. They can be textured or smooth. They do not require form stability, and hence most surgeons use less cohesive gel due to its softer, more natural feel. However, over the last decade, we have realized that highly cohesive gels offer more control in directly impacting shape onto the breast, whether for accommodation or for reconstruction. So, therefore, implant manufacturers have produced round implants alternatives with high cohesive gel as well. It is currently unknown how the use of high cohesive gel in a round implant will affect its final impact on breast aesthetics. Supporting this concept, some have utilized imaging techniques to examine the in vivo shape assumed by the fourth generation round implants and found that in the upright position, they take on a contoured shape comparable to that of anatomic implants. It remains, though, to be seen whether these factors will significantly impact final aesthetic outcomes. Many studies, beyond expert opinion, have demonstrated that both plastic surgeons and patients have great difficulty discerning aesthetic differences between shaped versus round implants, and that both are equally aesthetically pleased. A very interesting study comes from Hidalgo and his colleagues in 2017. It was a randomized controlled trial study where the 75 patients received primary breast accommodation. Intraoperatively, they temporarily placed either a round or anatomical cohesive gel implants subpectorally in one or the other randomly assigned breast of a given patient. After taking upright photos, 10 plastic surgeons and 10 others blindly evaluating breast aesthetics. It was interesting that 44% of plastic surgeons and 29% of others could not detect an aesthetic difference between the sides. Also, it was more interesting that when a difference was noted, neither group preferred one side over the other. Debate, though, exists over the conclusions of this study and similar studies. And indeed, there is a limitation here that it was done in primary accommodation and the results do not necessarily apply to breast reconstruction cases where greater control of implant dimensions may be helpful. This limitation, though, was explored in another recent retrospective study by Dorfman and his colleagues in patients who received two-stage submuscular breast reconstruction after nipple-sparing mastectomy. They found that nipple position geometry and aesthetic outcome were slightly more favorable in the anatomical implant group. By contrast, another cohort study by McAdam and his colleagues comparing the visual aesthetics of round versus anatomical cohesive implants, also in the reconstructive setting, found that implant shape had no difference on patient satisfaction with their breast or with the overall outcome when it was measured. Also, the impact of implant shape on complication rate is an area of active research. Things are not clear there either. And this is because in terms of shape alone, the most important complication of anatomical implants is malrotation to 1.1 between and 2.7% of patients in the papers, which we don't see in round implants because of the radial symmetry, but rarely, but also they can flip in an anterior posterior vector. In conclusion, it appears that in the hands of an experienced plastic surgeon, the shape alone of cohesive gel implants is likely to impact either it's unlikely to impact either patient satisfaction or the aesthetic appearance of the reconstructed breast. It doesn't matter. Let's move to the second question. Shall we use texture or smooth implants? We know that current shaped implants have a texture surface that is presumed to provide better adherence to the surrounding soft tissue and to minimize implant rotation, we just said. There is clinical evidence demonstrating less capsular contraction with the use of texture surface devices. Many believe that smooth implants are associated with increased rate of capsular contraction, as you can see here, as compared with texture implants, especially concerning prepectoral placements. There is a study, a recent study from Calabrese in 2018 of Centra implants, where they found that the odds of developing capsular contraction was 4.5 times greater with smooth implants and 4.6 times greater with prepectoral placements. Multiple meta-analyses support these conclusions. There is, however, a growing body of literature not convinced of the smooth surface and capsular connection, especially with the use of MS.
Ό,τι σου έρθει, ξέρω εγώ, να μην το έχω πάρει στο κρανιό τώρα.
As noted by Adams and Malucci, there are as many level 1 studies that have not supported the association between texture implants and capsular contraction as there that they have supported. That's interesting. Also, studies offer contrasting findings. Some reports indicate decreased capsular contraction rates with texture implants relative to smooth implants. Other studies, however, found no significant difference between smooth and texture implants, or between smooth and large pore textures in saline implants. In addition, when we have a radiation, reconstructed breasts, the capsular contraction rate remained high even with texture implants as well. Recently, we are aware of another medical emergency, the anaplastic large cell lymphoma has been a public concern. It's associated with the use of texture surface breast implants. The lifetime risk is estimated to be approximately even 1 in 2,200 or up to 1 to 8,000, 86,000. So there are more data need to come in. Although rare, it is a potentially fatal condition, but readily treatable if identified and managed appropriately. The connection between texture implants and postoperative complications such as the ALCL or late seromas or double capsules has received a significant amount of attention recently. All these variables may be related through some common mechanism, biofilm formation we all are aware of it. Late seroma, we all know that is an asymptomatic fluid collection that develops in the periprosthetic space at least 1 year after the most recent breast implant operation. And most cases have been associated with macrotexture implants, in particular biocell texturing. Although rare, the late seroma as well, it is concerning because of its similar presentation to the LCL, which is also associated with texture implants. In this photograph, it's one of my patients who had breast reconstruction with an anatomical texture implant 12 years ago. And recently, she presented to my office after a few years, facing this very the picture you see, which it was a very big seroma. A recent European population-based case control study confirmed the association of ALCL with texture implants, and the number of women with implant needed to cause one case of ALCL before the age of 75 was 6,920. So you see the numbers vary. The question is, until the etiology of ALCL is determined, is it wise to avoid the use of texture cohesive implants? Of course, I'm not sure on that, and I can't really give a definite answer. There is currently, though, no evidence that the difference in aesthetic outcome exists between textual anatomic implants and smooth round implants in breast reconstruction. Here you see her result after drainage of the seroma, of course, capsulectomy and replacement of the implant with a smooth, this time, a round implant and the use of MS. Now, the decision-making tree multiplies when we add to this the concept of the bioengineered breast, wherein regenerative cells and scaffolds are used to further define breast shape and feel. Technological innovations have been instrumental, particularly the use of meshes of tissue matrix or synthetic origin. We heard a lot of this today as well. These new materials have a low profile, rapid tissue integration, and a long-term strength retention profile. To mesh or not to mesh? The benefits of a mesh include soft tissue support, elasticity, less scarring, and achievement of device compartmentalization. This photograph is kindly borrowed by a very interesting paper by Nahabidian, the Bioengineering Prosthetic Breast Reconstruction, Advancement, Evidence, and Outcomes in 2019. I think I have 2 more photographs. I found it useful to bring in the presentation. Meshes have gained popularity for use in all forms of implant-based breast reconstruction for many reasons. Some of these. First of all, they can help in expansion of lower poles with hammocks and slings, to the extension of the pectoralis major muscle, in order to achieve one-stage techniques reconstruction, for soft tissue thickening, to reconstitute the inframammary fold, which is very important, for compartmentalization of the device, as we said, to minimize the inflammatory response associated with the implants, as is shown from many studies, also to prevent it, sometimes to treat the capsular contraction, because it is an alternative when you have patients with multiple capsular contractions to use a mesh with the implant, if they want to go to have another implant as well, to treat rippling, symastia, malrotation, and of course the bottoming out, which is very well known to us as plastic surgeons. Why not to mesh? It's cost effective, they have a high cost. Well, if you have healthy and well-perfused mastectomy skin flaps, there is no need for that. And if we can achieve high quality outcomes without a mesh. So the mastectomy type and the incisional design is also important to decide to mesh or not to mesh. Preservation of as much of the native skin envelope as possible is preferable over tissue expanded skin to maximize breast aesthetics. Therefore, preoperatively, the plastic surgeon and the breast surgeon, they must work together to design the incision to meet both reconstructive and oncological needs. Also, the number of stages, as we said, and Dr. Angelopoulos said before, is very important. These days, we can achieve reconstruction in one stage. It is not always the case, so we don't forget the 2-stage technique, but the mesh will help us very much when we can, because we can put now the implants partial subpectoral, as you can see in the photograph above, and also for prepectoral placement, we completely cover. You can mesh the mesh as well, so we can achieve direct to implant breast reconstruction a lot easier, or perhaps we can achieve it with, we couldn't do that in the past without a mesh. But we should not forget that ADM is fundamentally a graft that relies on revascularization by the overlying tissues. Therefore, we have to be very careful to use a mesh, for example, in a diabetic, in smokers, where there is a history of radiation therapy. And in the end of the day, if we can achieve a submuscular, full submuscular pocket without a mesh, I think it's always worth it considering it. In 2016, Salzberg and his colleagues assessed the rate of capsular contraction in 863 patients who received mesh-assisted direct to implant breast reconstruction. The findings were very interesting. The capsular contraction rate was 0.8%, with all cases occurring the first 2 years after reconstructive surgery, with a good follow-up of nearly 5 years. Most importantly, 97% of the implants they used had a smooth surface. The data, the controversy regarding the use of mesh is a complicated based on the surgeon's philosophy, but the data regarding the use of meshes are mixed and include supportive and non-supportive outcomes. How can we answer finally the question? I believe an algorithm approach based on high-level evidence is difficult because the early data outcomes are similar between prepectoral and dual plane reconstruction surgeons' opinions are polarized. However, the data do support that capsular contraction rates are less when meshed are used. This is an interesting study where you can see the drop from nearly 20% down to nearly 4% capsular contraction rate. Experimental studies have demonstrated that capsules surrounding implants without a mesh in the setting of radiation to be associated with prominent inflammatory infiltrates and pseudoepithelial cells leading to prominent capsules. Whereas implants with a mesh, with an ADM, tends to have less cellular invasion, a delayed or diminished pseudoepithelial formation. Also, clinical studies have demonstrated that the effects of radiation are likely to be very similar when directed toward normal dermis or revascularized ADM. And also infection rates following prosthetic reconstruction tend to be increased in the settings of radiation therapy, but do not seem to be different based on the use of mesh or not. Concluding my talk, in choosing the ideal breast implant, many factors, I believe, must be weighted. In the absence of data showing that shaped implants are aesthetically preferably over round implants, we must turn to a risk-benefit analysis of the complication profile of each implant. Because shaped implants are textured to avoid malrotation, they suffer from the drawbacks of all textured implants, including a growing association with the Lcl. This needs to be taken into account these days. With the advent of round implants with varying levels of cohesivity, greater dimensional control can be achieved with our implants as well. With tools of the bioengineered breast paradigm, contour deformities can be corrected. With the use of meshes in breast reconstruction, rates of capsular contraction have dropped, putting smooth and textured surfaces on equal footing with respect to capsular contraction. I believe it is important to emphasize that a multitude of combinations of these variables is possible, and that an individualized plan that considers all factors should be developed for each patient. During the preoperative consultation, all the advantages, disadvantages of the different types of implants available for breast reconstruction should be carefully explained to the patient and to ourselves, of course, to meet the optimal implant-based breast reconstruction outcomes. Thank you very much for your attention.
Thank you, Dasos. I know it was a huge thing to cover. So up to now, we've covered a lot of things having to do with implant-based reconstruction, direct tree implant, expanded tree implant, round implants, texture implants, anatomical implants, mesh or not to mesh, but there is a big question that we haven't answered yet. And I think we should talk about that and then go to an overall questions and discussion about the implant-based reconstruction. So, Michalis, I think you should take over and present the next speaker. And then after that, we should have a comprehensive discussion about everything, if you all agree about that.
Yeah, okay, so let's move on. It is becoming more and more fashionable to use, as we just heard, to use pre-pectoral implants with the advent of the new materials we have, including the meshes and the new implants. I have the honor and the privilege to introduce Mr. Giorgio Berna. Mr. Berna is the Director of Plastics, or should I say Doctor, sorry. Dr. Berna is a plastic surgeon, a Director of Plastic Surgeon in Veneto, Italy, and he has participated in the development of consensus about the proper patient selection for pre-pectoral use of implants. So Mr. Berna will talk to us about the pre-pectoral regenerative implant indications and technical tips. Giorgio.
Thank you. Good afternoon. Could you hear me well? And it's a real pleasure to be here with you. And I thanks a lot because it's really an honor for me to share my experience with the pre-pectoral implants and ADM, of course. So let's start. Let me see one moment, one thing. I'm sorry for this. All right, so this is my disclosure. And what is a regenerative implant? we use during our practice a lot of biocompatible implants, but they are not regenerative. Regenerative, according to us, is something that helps the body to stimulate the physiological healing process and also helps the cell and tissue to restore function, the integrity of the damaged sites. Because why is this so important nowadays? Because when I start with the prepectoral procedure in breast reconstruction in 2012, there was, and they use only an IDM. Nowadays, we have seen a real increase of the prepectoral technique. As you know, we have a lot of material, but how we can see later, there are a lot of difference between these. From the beginning of the history, there was a really conflict between the man and the nature, with a lot of products that was product to last in time. But how we can see, despite of this, nature tends to degrade them, integrate and eliminate them. And this is more similar what happens with our breast implant, because silicone breast implant used for reconstructive surgery or cosmetic procedures has been designed to last in time. But however, the body tends to degrade, incorporate, and eliminate it. And this is the enemy number one for people that are using breast reconstruction with implants, the capsular contracture. Of course, it was for this reason that at the beginning of the history, the surgeon changed their plane from a prepectoral to a subpectoral plane. Just have a look to the history to this lady that had an implant in a subcutaneous plane that is really a restoring plane with a good aesthetic result, but pay attention, result in a short term. If we go in a long term, something changing, and is a rapid and efficient procedure. But I will just say the high capsular contracture rate, like this work shown us. So we had incidence rate of Baker 3 and 4, 40% with prepectoral, subpectoral 11%. Let's go on with the history. We have introduced in 1982 of the Radovan procedure, so the tissue expansion, and in the 2005 with the work of Broing, the first compare of ADM. And also this is my first talk in Milan to the NAVA meeting for the first prepectoral on the world with the ADM. So what is the difference between a prepectoral plane position and a prepectoral regional implant? Let me show my idea. And you know, I've seen before, we have no animation, of course, in prepectoral position. We have a less functional impairment. It's a natural aesthetic result, but we have a high risk of capsular contractures. We lack of mechanical support Salisbury needs. Instead, if we use a prepectoral implant with a regenerative implant with an ADM, in this case, we have an easy implant with a better symmetry. We have a reduction of a capsular contracture, sorry. And so we have a quite of protection to the LCL, as you know. One of the reasons LCL could be the direct contact between the body and the implant. So we have also a good distribution of the loads, a good biomimicry of the Cooper ligaments. Let me show what's happened with the complete ADM coverage. Despite of submuscular ADM or just an ADM put it above, with the complete coverage, we have a good distribution with the lobe, a good integration of the biomaterial, and so we have a good aesthetic result. So the prepectoral positioning alone does not guarantee tissue regeneration, according to me, because when we speak about a breast reconstruction in prepectoral plane, we have to analyze also the biological aspects. And in this speech of the 2017, the authors make themselves a question: do we always need AIDM? And they conclude, no, we don't need always the AIDM. And they show us this kind of complication that you can see on your left. But if we compare the IBAG study, the largest study in the world with the prepectoral, with the same AIDM, you can see a really different rate of complications. So the answer of this question is yes, the AIDM is really useful in our practice. If we have a look to what's happened in the micro situation, it is under the electronic microscope, and we have this kind of magnification on the left when there is a synthetic net, and on the right we have a AIDM. And if we put inside a fibroblast, as you know, is the first cell that came in a foreign body, in a foreign AIDM, sorry, in a foreign net, or okay, you can see a different situation. In using the synthetic one, we see that the fibroblast is alone. If we put on the same situation, same magnification, you can see that on the right with the synthetic, the fibroblasts have no choice to integrate with the body. There is no space. There is too much space. It's like to put two people in the same room, in the different room. They can't have socialization. Instead, on the right, you can see how this field is very comfortable for the cell to improve yourself, to have a new regeneration, to have blood integration, and so on. So this is really different. And speaking about this case, this is a young woman that came to me after 9 procedures with a synthetic net. You can see after 9 years, we have not nothing integration, we're not integration. So only mechanical, only putting something over the muscle is not enough to have a good result, a good regeneration. So I've written here, in contrast to the synthetic material, extracellular matrix scaffold retain many of the native proteins and the 3-dimensional structures, creating biomateriality that more closely mimic human tissue, and so on. So the AIDM, according to me, and the biological materials speak the same language of the body. Okay, what is the right material? We have studied a lot around this kind of material, this kind of AIDM. We think that the right material has had a thin of 0.6 millimeter, AIDM in natural collagen, not cross-lingual, no chemical advice, sterilization method that does not damage the colon structures, a AIDM that allows a complete cover to reduce the risk of capsular contracture. Our criteria of selection were changed in these 80 years. At the beginning, it's 10 years, of course. At the beginning, we have that these criteria. Sorry. And nowadays, we have just a differentiation of criteria, because nowadays we think that we can use this kind of reconstruction if we think that our patient can go to radiotherapy. And is more important the blood supply than the thickness of our flap after mastectomy, you can see in this picture. So the biological aspect to consider for a regenerative perpetual implant revolve around the implanted material and the surgical technique. Let me see our technique. I will listen before a good reconstruction with a good mastectomy, so don't use electrocauterius in the space between the glandula and the skin. You can use in the prepectoral plane, of course. I am plastic surgeon. I don't do the mastectomy. The general surgeon do, the breast surgeon do. And after the mastectomy, we check our flap that is good for our implants, and we go to start. So our tools are respect the subcutaneous tissue, gentle mastectomy, limit electrocautery to use it, use a cold blade, and don't use the povidone iodine because the povidone is like cytotoxic for our IDMs. It's really important to maximize the adhesion between the IDM and the vascular tissue. We have to consider the IDM like a skin graft. Refresh the bondage at the end of the surgery and separate the mammary and the axillary incision. Use breast implant of moderate size and to be faster as shown. So I repeat this important concept to have a good integration, a fast integration between the IDM and our implant and the body. Use a complex bra after surgery, remove damage when the collected fluid volume is about 30 cc a day. Avoid excessive arm rest movements. And this is the new implant, the new IDM that now we are using is called Braxton Fast. Is really fast to make this kind of procedure. You see on the right the old procedure, and this is the new one that permits us to respect a lot of time. It's very important to have a good adhesion between the ADM also in the middle part of the breast, and we use the pulley technique as you have seen in our movie. So we use absorbable suture and so on, and we are going to finish. So this is the advantages of the new procedure, the new IDM. And these are our aesthetic results, but I've seen a lot of good results. So I know that you know how this procedure can help us to have good outcomes in a long follow-up. How you can see, people are really satisfied of this kind of results. They are very comfortable, they have no pain, but I know that all your things you know very well. There is another movie, another patient. And I'm going to my conclusions, also to show how is really software, really natural, the outcome that we can achieve with this kind of technique. Also when they jump or they make sport. This is the new ADM, so the follow-up is shorter than the other ADM, of course. This is pre or post. And also we can use this kind of mix from aesthetic and reconstructive surgery when we decide to save to make a nipple sparing mastectomy with the procedure of mastopexy. In conclusion, the prepectoral procedure is indicated in selected patients. It's very important to perform a good mastectomy. The use of immature materials leads to prospective fibrosis and increase accordingly the risk of capsular contracture. The prepectoral position alone does not guarantee tissue regeneration. The prepectoral regenerative techniques needs a coverage with a bioactive material, an ADM, because the patient is self-tissue, therefore biochemical ligands for a physiological loss distribution. And we have also a capsular reduction. Thank you very much for your attention. And thanks again for your kind invitation.
Thank you. Giorgio?
I think, Michalis, we have lots of plastic surgeons around, so it will be a good chance, and we have lots of time because everybody was very short. So we have lots of time and lots of discussions and lots of questions. I think I would start with Mr. Venizelos and Mr. Sanidas for any short question or comment, and then we should carry on with the more discussion. And be free. I think Mr. Nanidis is here. If he switch on his camera to a microphone, he can join us, and maybe between
Awesome.
you plastic surgeons, we can have a good conversation. Vasily. Microphone.
Despite the problems, very good presentations. Congratulations to both of you. I would like to ask Dr. Adamopoulos only to Dimitris, if you can outline the criteria to use prepectoral versus subpectoral reconstruction. I mean, because it wasn't very clear how you are going to decide which type of reconstruction you are going to use in one stage reconstruction.
Yeah, okay, thank you, Vasilis. My concern about this type of reconstruction, in one stage reconstruction, is to achieve the good result. I don't mind if this good result is going to be produced using the subpectoral or prepectoral. So I can say in surgery, after having done the mastectomy, the breast surgeon, where every plastic surgeon must be from the beginning of the surgery. So they both can evaluate the tissue, the overlying tissue, what type of, how much subcutaneous tissue remain under the skin, and how the develop is relaxed or not. So, and then you can take the decision on the table. So we must be flexible. So my first indication is to get the good result. I don't mind if this happens subpectorally or prepectorally. On the other hand, using this technique that I showed you before, the selective denervation of the muscle, which I do for the last 5 years, and I feel very confident on that. And I do it even in the aesthetic cases in breast augmentation when I put the implant before under the muscle. This technique works perfectly. You can't have any animation in the long term. So solving this problem of the animation, I don't mind. The only thing that I have to think about is the thickness of the overlying tissue. The first thing. The second thing, I use the polyurethane implants, as you know, and I'm very happy with using this polyurethane implant, and moreover the Be-Lite type of polyurethane implants. And the third thing is I don't like to use a huge amount of any foreign materials in the body. So those are my criteria.
I think we should go back to Dr. Berna for give us the other side, using more materials, a lot of materials in the breast.
Yes, I do, because I think that we have to avoid the direct contact between the body and the implant, of course. This is very useful to have a good follow-up with no rate of capsular contraction. I don't really agree with my colleague that spoke just before, because when you use polyurethane, you use a foreign material, because as you know, after 6 years, the foam is compared, and you have just a smooth implant. inside the body with the complications that are just equal to the simple implant put in the prepectoral plane. This is my idea.
So I think now is the time to ask Mr. Tsakouras, who is responsible for all this debate. Which material? Polyurethane or not polyurethane? Mesh or not mesh?
According to me or according to the colleague?
According to Mr. Tsakouras. To Mr. Tsakouras.
Okay. Yes, sorry.
Well, I'm a little disappointed after half an hour of lecture with canned answer. Anyway, I think it's really difficult to answer. I agree with Dr. Antonopoulos, with Dimitri, that it is an algorithm. You have to decide. I don't think you have to have just a solid opinion and to do only this, all of the other. There are many, there are sometimes many parameters that you have to take into account. And sometimes some of these parameters are not only medical, but can be financial as well. For example, meshes today are very, very expensive. Not all of the health systems support the use of mesh. I think in Greece, so far, in the private sector, at least where I am, they don't support the use of mesh. So it's not easy for some of the patients, or for many of the patients that I see, to support financially the use of mesh, for example. On the other hand, also you have to take into account the medical history if you have to use a mesh. Generally speaking, in my personal experience, it has been a fantastic innovation. I do use the mesh not only for reconstructive cases, but even for aesthetic cases, especially, and very often I use it for reduce. So if I have to do a reaccommodation, for example, after a few years, or when I have a capsular contraction, then I really consider of using a mesh. Not always the ADM, which is really very expensive, but I have used a lot synthetic meshes, which are less expensive, with very good results. But I don't like talking about my personal experience because the numbers, at least that I can say about, they're not too many. So I like to look into the studies. And looking into the studies, you see that there is a controversy. You see there are interesting papers coming from both kind of answers. And I think future will make us even more optimistic, because what we didn't say is that as we speak, I think innovation has moved even more forward. We're talking now for nanotechnology. We're talking now for creating more special kind of meshes via nanotechnology. We're talking now about different, ALCL gave us a lot of concern. Is smooth implants? I'm not convinced that smooth implants are the solution, because when I started my practice, I remember everybody was contending smooth implants and was moving to textual implants. And now it's so simple to say, let's go back to smooth implants, particularly without a mesh, because perhaps we will see again the capsular contraction rates to raise. But there are new devices, there are manufacturers that they create a sort of nano texturing implants. And, I don't want to give names, but everybody knows. But so I think the future is more promising, Sophocles. And for the time being, experience is that matters, I believe. And using algorithms, what is better for the individual patient we have in front, and collaborating, multidisciplinary team in everything, collaborating with the breast surgeons to achieve the best results.
Since we have Mr. Lanidis with us, Theo, would you like to give us your opinion about what you usually use or what do you prefer?
Yeah, hi, Sophocles. Thank you so much for the invitation. Some great talks. I think the other speakers probably have a lot more experience in implant-based recon than me, because I'm mainly microsurgeon, but I've done a few, obviously, implant-based reconstructions, and we have moved away from sub-PEC to pre-PEC pretty much exclusively now. And we tend to use ADM pretty much again routinely. And the one we use is the meshed surgiment. So we've gone from using very thick ADMs to very thin ADMs, more to control the inferior pole. As Mr. Tsukura said, I think a case-by-case scenario is the best, and depends on the patient habitus, depends on the thinness of the skin. I think that reconstruction is very much dependent on a good mastectomy as well, and I see that in the microsurgical reconstructions as well. The nicer the mastectomy is, the better the result. But I think I would always probably use a mesh or something in the inferior pole to control that. We've kind of moved away from polyurethane implants, really, unless the cases are very challenging and repeated capsular contractions, perhaps, because of the risk of ALCL. But we do use Polytech a lot. They're micro-textured implants. But as I said, mainly pre-PEC and with meshed ADM. That's my experience.
May I ask a question, please?
Sure.
Thank you very much, all the presentations. I would like to ask Dr. Berna. He said that the mastectomy is being done by the breast surgeon. Are you present during the mastectomy, or you are entering the surgical environment after the breast surgeon is gone? Because I've seen that happening in Germany. And my second question is everybody, all the plastic surgeons, directed to the choice they did preoperatively, or they are ready to change their technique from pre-PEC to post-PEC, or have a flexibility about that? Because me, working in the private sector, my plastic surgeon decides before what we're going to do, and we order 2 or 3 sizes which they come, and that's it. And I'm always anxious, what will happen if we have to change? What is happening in your institutions? Do you have enough materials and prosthesis around to change your techniques? Thanks very much.
Thank you for a good question. So I work in a breast unit. I are really every hours every day in contact with my breast surgeon. Me or my colleague in the operating room during the mastectomy. We see all the patients together before the operating room. We see 1 week or 2 weeks before. We see the mammography together, and we see if he's allowed to do a prepectoral or not. So there are all of these points are decided together. And also in the operating room, we can change our choice. We are able to change to put a tissue expander, or to pass from a prepectoral to subpectoral if we have not a good tissue or a good blood supply.
Thank you.
Thank you.
Can I say something, please, as well? Can you hear me?
Yes, Tassos, you can.
Yes. Okay, thank you for that. I really, it was a very good question by Dr. Saneda. And I want to enforce as well that I believe as well that the plastic surgeon has to be with the breast surgeon from the beginning. In fact, in my view, the plastic surgeon has to be with the breast surgeon even before the day of operation, because they have jointly to decide what is best. It scares me sometimes that I see or hear, you can say, some colleagues that just step into the operating room without even knowing the patient. Now, personally, these days, I have more and more often a mesh on the side in case I need to use it. I believe that most of the time, the plan is decided before surgery, but things can change. For example, if a breast tissue is very, very anchored to the skin surface and you have very, very thin skin flaps, then perhaps the use of a mesh is unavoidable, whatever technique, because you don't use the mesh only in 1 stage breast reconstruction, you can use the mesh even in 2 stages breast reconstruction using expanders as well. So I think collaborating and being together in theater is very, very important.
I think that's the main message of oncoplastic surgery, I guess. Before Mr. Antonopoulos answer, I think Vasilis has a question. Mr.
Yes,
Venizelos.
thank you, Sophocles. I would like to ask Dr. Byrne about the use of the radiotherapy after the one-stage reconstruction with mesh, because nowadays few cases have been done as one-stage procedure. Can we use the radiotherapy treatment just in case we need it?
Okay. Yesterday, I had a meeting in Italy with this point, speaking about radiotherapy and the perpetual implant with ADM instead of implant with polyurethane also on. I've seen a lot of literature about this point, and I conclude that we have not a lot of paper about polyurethane and radiotherapy until now, but it's normal because polyurethane in perpetual position is new instead of ADM. So if people made radiotherapy before, I think that is not, we have not allowed to use an ADM implant. But if they do radiotherapy after, we have just a lot of paper that thinks that we have a sort of protection, not a lot of one, but we have a 6% of capsular contraction with the use of IDM after radiotherapy. And if you don't put the IDM, but just a perpetual implant, we have 10% of capsular contraction. So we can conclude that the IDM is a sort of protection.
Thank you. Thank you,
Mr.
Giorgio.
Antonopoulos wants to say something.
Yes, I agree with Tassos Tsakouras, and my answer is to Dr. Sanidas. We prepare for everything and for anything, because our purpose is to operate the patient, not to do an operation. So in the surgery, we must be prepared and we must be flexible to change our preoperative planning. First thing. The second thing is that I think this problem with post reconstruction radiotherapy in one stage, I think it's a big thing to answer, because there is no data still, because the materials are different, and I think we wait to be sure and see. I feel more comfortable to put an expander in that case, because you think you have the second operation and you have many other things to choose in the second operation. Sometimes we move from the subpectoral tissue expander in the second stage to put it in prepectoral position, and there. Okay, so I don't think that we can answer about this post-mastectomy radiotherapy in one stage very, easily. This is my opinion.
Thank you, Dimitris. I think we'll have to stop the discussion here. If we let it go, we'll go on talking forever. Thank all the plastic surgeons. I keep the message that you have to be ready for everything. Experience is important. And as an oncological surgeon, may I add that patients have comorbidities, patients may have postoperative radiotherapy, patients may have had preoperative chemotherapy, which reduces the defense lines. So everything should be taken into account, and we have to be flexible. We're going to move on, and Sophocles will present the next presenter. Thank you.
So, as you have seen,
thank you.
As you have seen in the whole webinar up to now, the main thing is to keep the nipple in the right position, because what makes the breast is the nipple, is the reference point of it. Most of congresses, most of webinars, and most of surgeons do not really concern about reconstructing the nipple, and that's a mistake, I think. So for this reason, we called a good friend of mine, a plastic surgeon from London, working in the Imperial College, I guess. And Mr. Nandi is going to talk to us about reconstructing the nipple in a surgical point of view.
Thank you, Sophocles, and thanks everybody for the invitation. It's very kind, and kalispera to everybody. I was trying to share my screen. Can you see it? I presume yes. Yeah.
Yes, we're fine. We're fine.
Great.
Carry on. Yes.
So as Soph said, my name is Theo, and I work in London at the Royal Marsden Hospital. I'm a consultant plastic surgeon there. I knew Sophocles from many years ago at when I trained at it was St. Mary's, wasn't it? St. Mary's Hospital. And I'm actually operating with Paris Tekis later, Soph, in the afternoon, doing an exenteration. So I'll say hi to
that was a completely different direction, I guess.
Yeah. So I'm just going to talk briefly about nipple reconstruction. I think it's a little bit of a dry topic, so you'll excuse me if I put a few flaps in there just to spice it up a bit. As I said, I'm a consultant in London since 2017. We're a small unit of 4 consultants and 1 locum, but we do a lot of work. We do about 250 free flaps a year, and I'm mainly focused on immediate autologous breast reconstructions. We're a micro unit. The majority of our implant reconstructions are done by our breast colleagues, and we get involved in the more difficult cases, or salvage cases, as sometimes we call them. We don't do that many delayed DIEPs, mainly immediate, and you'll see the difference between obviously the two and where the nipple goes. So what, in my opinion, is the best nipple reconstruction? And actually, that answer is simple. Is no reconstruction at all if you can keep the nipple. You can never really recreate the nipple as the innate one was, and whenever I can in autologous reconstruction, I'm trying to keep the nipple, of course, in discussion with my breast colleagues. And there are a couple of approaches, of course, periareolar incision with a vertical extension where you can access the breast and do a mastectomy. And I now close most of that plus part of the vertical scar and leave a little bit of a paddle for monitoring the flap. And you can take this out either 2 or 3 days later under local anesthetic, or in a few months when the patient comes back for a revision. But I think the innate nipple can never be replaced, and the breast looks so much better and a lot more natural with the original nipple. Obviously, the other approach in the inframammary approach, I mean, this is a tug flap from the thigh, and this is a DIEP, of course, from the tummy with the scar down here. And this will have a little paddle underneath, which you can never see, and you can take it out or leave it. But the breasts look far better with the original nipple, of course. If you look at immediate reconstruction, so skin-sparing mastectomies where the nipple has gone, then you don't really have much choice of where you're going to put the nipple. It has to go somewhere in the paddle, and that choice is very easy. This was a ballet instructor, and I managed to get quite a lot of volume out of her abdomen. This is a bipedicled DIEP, and this is one of them with 2 pedicles, 1 on each side, where you then join to each other and do the chest. But I guess this is not a microsurgical talk, but I thought I'd show you a slide. This is the lady you saw. This is before the mastectomy, and this is with the DIEP and the nipple reconstruction and the ultimate tattoo. You get quite a nice symmetry. In the hospital where I work, the dyes we have for the tattoo are not permanent dyes. So as you can see, they're a bit lighter than the normal areola, and sometimes they need to be topped up. If a patient goes outside and gets a professional tattoo, then obviously the dyes are much better and they're permanent. And we are trying to change that slowly, but the trust will not allow us to have permanent inks. Same patient again, you can see the stages, before mastectomy, and flap, and then after the tattoo and the nipple reconstruction. In a delayed DIEP, it's slightly different because you've got a big choice of where you
Hello.
Hello, I'm not sure if I'm still on. I think I'm.
Hi, Theo. We lost you for a few seconds.
Okay, am I back again?
Yeah, you're back again. Yeah. We were all lost, so don't worry. Everybody
That's
was
all right.
out.
Should I wait or should I carry on?
I think you should carry on.
Okay.
We can hear you.
No worries. So as I said, in a delayed DIEP, I give the patient a choice with a sticker where they want the nipple reconstruction, and of course we measure it together. And you can see this is a delayed reconstruction with the nipple reconstruction and a tattoo. If you look at the patient up front, I haven't got it 100% right, and sometimes it's difficult to get it bang on. It's harder in a delayed reconstruction, but it's pretty good, and she's very happy with the result. If you look at the right breast, I have also fat grafted her normal breast because she liked the volume of the diep, and I took her flanks, as you can see, the love handles, as we call them, just to give her a little bit of a better cosmetic contour with liposuction. Another approach is, again, to keep the nipple in very thin patients. And I'm probably the only one who does this in the unit. I fat graft the pectoralis muscle at the same time as the mastectomy. It doesn't give you a breast, but it does give you a mound in people who are very small breasted. And if you keep the nipple, they do have quite a nice outcome. This is at, I think, a couple weeks, and this is at, I think, 6 months. And I'm going to repeat the fat grafting just to give it a little bit of a lower pole fullness. And sometimes I use the chrysalix system to show these patients what they're going to be like with a mastectomy and with a fat graft, which mainly goes at the upper pole in these patients. So going back to what we spoke about before, a lot of cosmetic surgery crosses over to reconstruction and vice versa. We've learned a lot about pre-pec reconstruction from, subglandular augmentation and vice versa. And I do cross both fields, and both of my patients benefit. If you look at some of the studies, clearly patients that have an NAC reconstructed have better outcomes, both in sexual well-being and satisfaction with the breasts. For me, this study really doesn't mean that much because the majority of our patients are given the option of having a nipple reconstruction. Pretty much everybody goes for it. The patients that don't go for it are very clear in the fact that they don't want it. It doesn't affect them, and they are just very clear about that, and we just don't offer it. I have proceeded to offer people more and more 3D tattoos, and I'll show you some pictures of that, as I think they actually look quite brilliant in some stages without an actual nipple. The drawbacks of a reconstruction, you get a bit more scarring, but that's not really that much of an issue. It allows you sometimes to fix the paddle of an immediate diep as well. You lose projection through time, and no matter what you use, even if it's cartilage, dermis, which I use, you do lose a bit of projection. As it's not an erectile organ, it's basically a bit of skin, so they always flatten. And it can be very challenging in implant-based reconstruction cases if you don't have a good thick tissue, because you find, for example, if you do a nipple reconstruction on a tug flap, it isn't as good as a diep, which isn't as good as an LD. It really depends on the thickness of the dermis, of the tissue that you have there, that determines the projection of the nipple. In implant-based reconstructions, we've lost a couple of implants attempting to create a nipple because of infection. And I think sometimes I have fat grafted implant-based reconstructions before a nipple if the patient is adamant that they want one. Lots of different flaps. I don't really use any of them. It's good for exam purposes. I've seen a skate flap. You have to graft them. I don't actually see the point of taking skin grafts for a nipple, but I mainly use a CV flap, which I will show you with a fat graft, a dermal fat graft, and then a tattoo, which nowadays is more often than not a 3D tattoo. So my modified CV flap technique, sorry about the baby diagram on the iPad, but this is the technique that I use, and I measure these to be a centimeter. They're all pretty symmetrical. If you consider that this will be your height of your nipple, so if you want to make a bigger nipple, you can increase this height a little bit. The second amendment that I've made is when you raise this hat, and you'll see the pictures of it, it will make more sense, you deepithelialize it instead of actually raising it with fat, because this hat bit will end up underneath your nipple, and then the nipple has something to sit on. I don't raise it like this. I keep it more attached with fat, both for better blood supply and also more integrity and structural integrity. And then I put a graft inside once everything is sutured up. This is a better representation of it. So this is what I mean. You keep it more attached here for better blood supply, because the blood supply doesn't just come from a bridge here. It comes from the underneath of the nipple as well. I've seen a necrosis of this, so it's especially in smokers. So this is a clinical case. I think I took some pictures in November for this talk. A lady who had an immediate diep. So this is a diagram that I use on the skin paddle. If you can see, it's roughly a centimeter, but you can vary that. Nowadays, I don't measure it. I just eyeball it. It depends on the thickness of the nipple. Contralaterally, you can make it bigger or smaller. You incise around it. I deepithelialize this part, so very superficial here, and then I cut full thickness across this line, so this remains a bit shallow. When you raise it, keep quite a bit of bulk attached deep, because it will give you some projection. Then close the donor side first, so this point to that point, and this is what you see here. And another trick is when you bring the corners together, so these two corners, bring the edge of it just across the midline a little bit, not just the midline. It gives better projection if you do that. And you can see this is ready for it to be closed. And in this hole here, I will place the graft. So most of our patients have a little bit of a dog ear because they're mostly immediate reconstruction patients. I've done some liposuction to her. So we'll take a little bit of a skin extension of the scar. And you can see here the graft with a bit of fat in it. It's a dermal fat graft. I would deepithelialize the skin and thin the little graft so it's not too thick. And then I would tubularize it. It's very easy to do with a Vicryl or PED. And then what you do is you slot this into the hole that you could see before, and you secure it so it doesn't drop in. And as you can see, this gives very nice projection both in the AP and looking at the patient from the top on this view. The dressing is a simple dressing, so whatever you have, Mepitel, Gelonet, whatever you have, and then a couple of iPads or any fenestrated dressing that you have, just for the nipple not to be squashed. So this goes over the nipple and then a new iPad on top, and you put a waterproof dressing over it. Patients leave it for a week, and when they come back, you do a wound check and give them a leave-in dressing or anything that's spongy with a hole that they then have to wear for about 6 weeks to protect the nipple reconstruction. This is a lady who had a mastectomy on the right and a Dieppe flap with a nipple reconstruction and a tattoo. As you can see, it gives a focal point to the breast. I would have probably liked the tattooist to go closer to the edge of the skin paddle, or should have really reduced the skin paddle when I did the nipple reconstruction. I don't think I was there. I think one of my trainees did it, but I don't really like this look. But she was very happy, and I did a vertical scar reduction on the other side, and she was happy with the result. As you can see, she has a very small innate nipple, so you can make a small nipple on the other side, which matches the patient's two sides. I've been doing more and more nipple shares recently, and there are a number of ways you can do a nipple share, and a lot of different descriptions of them. Some people just decapitate the other nipple and allow this to heal by secondary tension. It does hurt a bit, so I don't like it. So what I do is I modify it a bit and I take a little bit of a wedge. This increases the surface area of the graft and actually increases the take and the survival of the nipple, and allows you also to close the other nipple. And this is one of those cases. This was a massive nipple on the right side, and I took part of it and transplanted it to the other side. And you can see it has taken and healed very well. It looks very different to a reconstructed nipple. I think much better if patients are committed and they would like, for example, a nipple reduction. And you can see the nice projection on the side. The other thing we've been doing is 3D tattooing, and this is Laura, our CNS, who does the 3D tattooing. And this is a gentleman called Alex Crook, who is based in Kent. He's a tattoo artist. One of my patients saw him, and he went to see him for a random tattoo and decided to look at her breast. I don't know how that conversation went, but he then said, "Can I tattoo your nipple?" And she said, "Okay, fine, whatever, go for it." She didn't mind. And then he posted the picture on Facebook and got something like 20,000 likes in half a day. And because of the response, he offered free tattoos for my patients from the Royal Marsden. And so he has a whole now queue of 6-month waiting list to do these 3D tattoos. And they can be fantastic. This is the original one he did. And I really had to go up close and actually rub this nipple to make sure it's flat, because even at interpersonal distance, this looked like there was a nipple there. And this was one of my LDN implants, which I very rarely do. She didn't want a nipple, she wanted a 3D tattoo. And this is the kind of result you can expect from a professional tattooist. This is one of our homemade 3D tattoos. I think Laura is much better now. This is one of the original ones because we spent some time with a tattooist just to show some of the tricks. This is a tug flap, and this is just a 3D tattoo for this lady. So in conclusion, I think the nipple does give a focal point to the reconstructed breast. All our patients are offered it. You've seen the kind of flap that I like to use. I don't really use anything else, maybe the double tub flap sometimes. But I've been using more and more tattoos recently, but I think most people do want some projection. And patients do love this final aspects of the reconstruction. If they forget about cancer, they have a nice chat with the nurse. It's a very different environment. They feel they've moved on, they've beaten cancer, and it's a nice experience for them. So I think it's a nice addition to the reconstructive journey that they go through. And thank you. That's all I have to say. Very simple. Any questions?
Theo, thank you very much for your excellent presentation. And what you actually show us is that simple things are the best things if you know how to do them right, actually. And you also gave me an assist introducing the breast care nurse in the discussion.
Yeah.
It's something that it really misses from Greece. But we thought in this webinar that it wouldn't be complete if we didn't have a breast care nurse. So the first thing I thought is the breast care nurse I worked with, which is Vicky Hammer, and she was excellent in the cooperation, and she actually showed me and proved that the breast care nurse is a vital team member of the breast care team. So I think with your assist, we're gonna let her talk about the tattoo, and then we're gonna have a little conversation about the nipple reconstruction.
Of course.
Vicky, nice to have you here. Hopefully you sort out the problems, and hopefully we're gonna be hearing you now.
I really hope so. Absolutely. I've come into St. Mary's Hospital, our old haunted stomping ground, it seems, for a number of the panels. So hello from London, and what a pleasure, privilege, and a joy it is to be here giving this talk. So many thanks indeed. The next hurdle, I'm slightly holding my breath, is the sharing the screen button. So I'll try that now, but once more I can look, and then hopefully we go for this one. And some may say that, oh, I'm just sharing. Come on, right, are we there? I think so, yes?
We are there.
Oh, you're brilliant. Hurrah, phew, all of those sleepless nights. So thanks ever so much. And actually, what a great day and what a perfect slot. Thank you, the insight of the committee organising this. And thank you ever so much indeed to Theo, who pretty much introduced and was a marvelous segue. So yeah, I'm going to talk about reconstructing with medical micropigmentation, or tattoo as we say. If I could just move it. So we've seen a smorgasbord of reconstructions, and the ladies will choose to.
Sorry, can you make the PowerPoint full screen?
Can I make it now? You're asking me. The fight there, you see, anything's possible. Thank you ever so much. So absolutely, it's up to the lady really, as well as the consultant surgeon and the multidisciplinary team, how far people want to take it. And as we've seen an array of reconstructions throughout this wonderful day, this lady has had a latissimus dorsi reconstruction. This is way back when, and she just chose to leave it at a nipple reconstruction. She didn't choose to have a tattoo. This lady, and I think this was when Sophocles was with us 100 years ago, back in room 4 of outpatients. And this lady, this is one of Mr. Hadjiminas's reconstructions, who we heard from first thing. The only comment I think some may say is that the bra is a little tight on that right-hand side where she's had the latissimus dorsi, again, reconstruction. She went the whole hog and had the nipple reconstructed and also the tattoo. So we see that there are, different pathways for people, and that there's the before and the after shot. We started our service at Imperial, which we are now, in August 2012. And I will show you, it's probably a lot of pictures of breasts, almost too many for some subliminal messaging throughout. But we really saw that there was a bottleneck. To start with, these people who were waiting for the nipple tattoos were on the queue for surgery. It was performed by the surgeons, it took up theatre space, and there was a lot, even up to 6 years wait list for these, as of course we were pressed to do the cancer operations, and these were very much thought of as an add-on, as a cosmetic operation for later. However, as we were incredibly lucky and we got some money bequeathed to us by a patient in her will. So we used this money, and so it was cost neutral set up. All the managers were highly delighted. Moreover, it's income generating, because once you have the kit, the machine and the training, then it's actually, you can income generate. I mean, in this virtual world of money, the patient waits less time with me doing this. And so I completed the recognised training, which was at the Royal College of Nursing, and decided, as we heard from the previous speaker, that yes, it is an appropriate add-on for a nurse. It's a delicious conversation I have with the women, because their dust has settled somewhat after their breast cancer treatment, and they're going back to their new normal. And so it's quite an intimate procedure, which takes an amount of time with just myself and them in the room. And sometimes we really get out a lot of sort of meaty discussion, and also how we can help them, as almost we release them into the community, I suppose. We created some patient information and a protocol. And of course, I audited the first 10 patients. I'll tell you about that later on. By chance me doing this, of course, it frees up the consultant surgeons. They were able to do more sophisticated reconstructions. And it also frees up the theatre time, which of course, as we know, it's the most expensive resource. There was no recovery time, and it's quite right and proper to use a clinic room. It also meant that patients weren't hanging around all day waiting for a slot in between cases and then rushed in. And so we started this back in 2012. And absolutely, as Theo mentioned, there's a number of different ways, a number of different patients' situations that I get. This lady had nipple sharing. So very much, as he alluded to, half of my work was done in the sense that the nipple had been shared, and so I only had to do the areola. So what we do is we use a template and we form, it's a little bit smoke and mirrors, and there's sometimes when the nipple itself isn't directly center stage of the areola, and that's if there is a bit of asymmetry. So we could help to bring it down, help cast the eye down. So we would do that with the stencil, as you can see, and draw around, and then we colour match. So there's a range of colours, and colour match, as you can see on the top right, to see which micropigment suits best. The bottom row of the pictures, again, the shinier one is after it's done, immediately after it's done, because in one sense, it's sort of traumatizing the skin. There's various combinations and that you can use, but I use a 5 mag, which is 5 needles in sort of a cluster. And again, in one sense, you're sort of causing trauma to the skin, aren't you? You're grazing the skin. So there is a bit of a meaty, red, bloody appearance to begin with, which I would then put Savlon on and a dressing, and then set the lady off. Again, as Theo mentioned, the tattoos are topped up, and I've got quite a nice routine in my diary where I see patients for twice, so 4 weeks apart. So I would see them, and then I would see them 4 weeks later for a top up, and the bottom right-hand picture is her afterwards. So there's a number of these reconstructive pictures. Again, this lady, again, nothing simple once you add the individual. This lady has not had a nipple reconstruction. So again, we're trying to do this 3D, or as I like to call it, the illusion of a protrusion. I don't think I've got any, I don't think the professional tattooist has anything to worry about me, my skills, but this was a lady, as I said, back from when we started maybe 10 years ago. And similarly, as you can see, this is how she came to me on the top right. You draw around sort of, again, a bit of smoke and mirrors, because you can see the asymmetry to sort of to balance it up. And then on the right hand side, on the natural nipple, you can see again a bit of color matching, one color for the nipple itself and a lighter one for the areola. And then immediately afterwards on the bottom left, and then 4 weeks later. So when she comes for a top up, again, that's how it is. So I have got quite a number of pictures, again, once more to show. This lady again has had nipple sharing. So similarly, half of the work is done. And for me, it was just the areola. So again, drawing that down, drawing the eye down, there is asymmetry as we see, but I hope that you could see on the diagonal, if we look at top left and then bottom right, you can see that is the before, and then that is at 4 weeks when she comes for the second sitting. So I would also suggest, if people are undertaking this task, not to be alarmed by the meaty appearance, which we've got bottom left, which was initially afterwards. Certainly if there's any surface, or a much paler skin, which again, a couple of slides I'm going to show you, you can think, or one can think, oh my goodness, you know, certainly if you're starting off, but have confidence. And again, it kind of depends how we do things. I think in any case, it does draw the eye in. As we heard, it makes a focal point. This lady has quite a extensive scarring. She had a delayed reconstruction on that left-hand side, and she also had a right mastopexy. So the scars there is a little bit fresh still. I don't have a picture of her 4 weeks later, but she was delighted with this. And again, I'm very pleased to hear from Theo that we got some of the patient experience data, because actually it doesn't really matter what we do, it matters what the person who's left with these wonderful reconstructions that you're incredibly skilled and expert at, matters what they feel and how that translates to them and to them being their new normal. This is an interesting point. And this was a gentleman, he had an LD, and he came up from Brighton. So those who know the geography in the UK, that was quite a commitment to him. But it didn't stay at all. He came up on a couple of occasions, and I don't know whether it was because the epidermis was a little thicker. I did make the tattoo needles. There's a point where you can open them out a little bit more. But again, it didn't stay, and it was quite a mystery. He was very body conscious, but again, it was the same process in the sense of sketching out a nipple and then tattooing. And again, that's quite meaty, that's quite fresh after, but I thought that was a little bit of interest for the future, perhaps. So this shows a whole series. This is a young girl who actually had quite a complicated pathway. She then lost the whole of the implanted reconstruction and had to wait. So you can see that the scar is quite marked. But she was delighted with the tattooing. As you can see there at the end, I cover it up with a dressing. I put some Savlon on it, just some antiseptic cream, and I cover it up with a dressing, and I say, don't touch it for 48 hours. And thereafter, they can remove the dressing and put, it's actually a sachet of Posh Vaseline on it. They use a cotton bud, a Q-tip, and put it on the wound there, and then water will just bead off the healing tattoo. And actually it will just, the little crusts will drop off and the skin will heal over the top. And as the skin heals over the top, it makes it much less, makes the color more faded. So we'll move on. There's a few more. This is a bilateral lady. And again, I think you could hopefully agree that it's always a benefit. I think so. I think it makes a huge difference. And I've had a number of women actually in tears, because it's the icing on the cake, if you like. It's the finish, it's a completed journey. And they're incredibly grateful to you guys, for rebuilding, reconstructing them certainly psychologically as well as physically. I'll move on now in the interest of time, but I hope that the picture on the right shows that you also do a bit of a blurred boundary. You don't want it like a bullseye, like a target. So there's a little bit of sort of blurring of the edge that you do. It works incredibly well with dark skin. Again, this lady, I tried to, as we heard from Theo, the previous speaker, he liked or did not like the fact that there was still a bit of the skin paddle left. So sometimes if the scarring is appropriate, and this may be something to bear in mind if you are reconstructing, I could go up to, or the tattoo person can go up to the paddle of skin, thereby concealing the scar, which we have done in this case. So again, bottom left is after I've done it, so a little bit fresh, and then 4 weeks later when they come back to me, and then I would continue for the second one. So I think I'll just speed up a little bit, but again, don't be frightened, don't be alarmed about after having done it. Again, top left is just having done it. Oh my goodness, are you sure? Yes, stay calm. Because when she came back again, top right, it had faded dramatically. I did top that up and continue. Again, same as same, and it very much depends on this is a bilateral implant lady, and again, this is afterwards, and then 4 weeks after. So I'll carry on. Again, similarly, these are relatively recently, having given notice of this talk, and yeah, well into last night was uploading these photos, so I'm delighted to share them with you, and thank you very much again. Once more, can't go up to the skin paddle with this rather Zorro-like, if I may, scar, but similarly, people were delighted. So I'll move on. Again, this is me, intimate procedure with the tattoo. With the COVID now, I wear the mask, and we have audited our practice. We audited it in, again, here we go, a few more. So we audited the service. We know it's vital to audit service so that we can improve, so that we can really match patient expectation to the service, and we can not rest on our laurels. I used the same audit tool when I started my practice in 2012. And yes, I learned from Sue Broom at the Marsden. I don't know if she's there still, but yeah, I went along to her and also to an external company. And it was this audit tool, incredibly simple. I did it in 2013, again 2015, and then after COVID, after I restarted the service after COVID, and a very easy thing. Firstly, a nod to myself, was my notes appropriate? And then looking at patient satisfaction, how informed were they in the whole process, 1 to 10, and how satisfied with the results, 1 to 10. I mean, they were incredibly generous with their scoring, but I will also just, I'll skip through a couple of these slides, but to really rest on the free text just for the last couple of minutes, if I may. So again, very generous they were, that they felt very informed. Probably there was, quite a lot of discussion. It doesn't matter, again, what color I think to put on. It's afterwards for the lady to confirm that's what she wants. One person has just come back saying, can you do a flower? Can you do a unicorn? I'm like, oh my goodness, I'm not so sure. I have done a love heart actually on one lady's breast, was the only sort of digression that I've had. So again, some of the free text is quite powerful. This was back in 2013, makes me look and, happy and confident, etc. We looked again in 2015, and again, thankfully, and probably because I knew I was auditing myself, all the medical notes were correct. And again, a lot of the women, most 10 out of 10, felt that they were happy with the discussion beforehand, and again, the opportunity that they have. Similarly, positive, happy, complete, and not ashamed of my breast again, almost normal. Again, that quite sort of, it's quite humbling to realize the impact of what we do. And actually, it's a privilege for me to have the time to get this feedback from people. So lastly, I'll talk about the same slides we used, again, the same topic, the same audit, apologies. 10 patients after COVID, we added a question about did they feel safe from COVID. And again, we had 4 right, a left, and 5 bilateral. We are now using electronic notes and electronic consent. And again, people felt very engaged with the, quite rightly, with the decisions about it. And similarly, some of the results there were incredibly powerful. Helped me feel more complete, elated, relieved. satisfying to know, gives me confidence, excited and pleased. And again, you know, really, I'm incredibly lucky. I appreciate that, to have the time to do this clinic. It's my favorite clinic of the week. I think my last slide is to, and again, thankfully they felt very secure COVIDly. I think my last slide shows that no matter how small a difference it is, I just conclude that this is a lady, no matter how small it was, and you can just about work out that I really just filled in the lower pole of the areola there. But this is a lady, she could be labeled as a bit of a tricky customer if someone was choosing to give out labels. Goodness knows what I would be if I was a patient. But she was someone who took a lot of input and had a lot of issues, and she'd seen the psychologist and all sorts. So there had been a really bumpy road for her. She was a very young girl. And even the smallest of the small, literally hardly even did anything. I got this, you know, incredibly sort of, it gave me goosebumps actually, feedback, which is saying about had she wished, you know, she had done it sooner. So that's for me now. So thank you for sharing the, allowing me to share this work with you.
Thank you very much, Vicky. And I will have only one small comment. This is what is missing from the NHS in Greece. There is, I don't think, to my knowledge, there is no center in the NHS that can offer nipple tattooing in the way it is offered in the NHS, and that's sad. I don't know if Michalis wants to comment something about that, and I don't know if Theo wants to say something about the whole nipple reconstruction in both ways. Michalis.
I think we should give the mic to Theo, and I will say something later.
Thank you, Sof. Is it with regards to the service in Greece, you mean? It's not a very, I think it's very easy to set up, I would have thought, Vicky. There obviously takes a bit of training and you require a small machine, but it's not something very complicated to get going with not too much funding. And I think it makes a big difference to patients. I mean, I remember when I was an SHO at St. Thomas's, they gave me the job to do many, many years ago because no one else wanted to do it. But I'm colorblind. I can't see color very well. So I made some really funny looking nipples. So pick somebody that can see color. But it's, if you have a CNS that we'd be more than happy to have over to spend some time with us to show her how it's done, there's no problem. I'll be more than happy to do that. I think it's important to set a service up because it makes a big difference.
Thank you very much. I think we're going to take that into consideration, and maybe we should send somebody there to both of you to teach us how to do it. Sure. I don't think Vasilis wants to make some comments about the NHS system in Greece and the lack of breast care nurse and the lack of medical tattooing without pain. The microphone.
Thank you. Thank you both of you. Excellent presentations, both. Unfortunately, we have some problems here in Greece, even to establish the breast care nurse here. We've been trying very hard, and I hope the next year we can do something about it. Tattooing in Greece in the NHS, although it's not very expensive, as Theo said, unfortunately cannot be provided. We have some private tattooing artists. We can provide this to our patients, but I think we need to have some change, to do some changes in the NHS, and all the guys that have been working in the NHS clinics, they can try very hard to establish this tattooing for our patients, because I think it's very, very important.
Can I say something, Sophocles?
Yes, definitely.
In my practice, I am every day getting surprised of how little women ask for nipple reconstruction and for nipple tattooing. I always mention this to them, and I think the digit is the number is one digit, single digit. It's less than 10% of women who have lost a nipple will ask for medical tattoo, even if it was free. And the second thing I wanted to say is take it from where Dr. Sanidas put it right at the beginning of this meeting. We had the privilege of working in 2 countries, and this is a big thing, I think, and we can compare. My experience is that the expectations, not the lifestyle, but the way we see things, we see our lives and our body is very much different between women in the UK and women in Greece. You cannot take a very experienced UK breast care nurse and plant her here. She will fail because patients want different things. Perhaps they're more afraid of cancer than UK patients. Perhaps they pay less attention to their appearance. I'm just saying perhaps. Or they give more credit or more value to other things like personal relationships, etc., and not the body image. This is a general thing. So what I want to say is we cannot directly compare the two countries, the 2 systems, and the 2 people. Although having a breast care nurse in my practice would be very beneficial for my patients too.
So just to close the section, I think the only reason they don't go for the nipple reconstruction is because they don't have a Vicky Harmer talking to them. Because otherwise they'll have gone every single one. I think that's the point. We need breast care nurses. We need the whole team to be working. We need to offer everything until the nipple reconstruction. I think it's very important. But I think we're a little bit late. So thank you very much for those excellent speeches. And Mike, I think you should move on to the next section.
Let's not be unfair to our last speaker, last but not least. I'm very privileged and very honored to have Dr. Dimitris Dionysio with us. Dimitris is a fellow surgeon, plastic surgeon from Thessaloniki. He's going to talk to us about all this new thing we learned recently, which is the large cell lymphoma, anaplastic large cell lymphoma associated with the implants we use for breast reconstruction. Dimitri.
Thank you, Michalis. I think you can see my presentation, and I hope you can talk me. You can listen to me. Thank you for the invitation. Thank you to the organizers, and thank you also to the society for the kind invitation. I'm going to talk about probably a new subject, a new cancer which we have to deal with. There is no conflict of interest in my presentation. And I try to divide my presentation in 2 subjects. First, to see a little bit about the breast implant technology. And secondly, mainly to discuss about the breast implant associated anaplastic large cell lymphoma, which I'm going to refer from now on as a BIALCL or ALCL for the time consuming. So breast implants are medical devices, and they consist of an outer shell, smooth or texture of a different kind of material, and the inner shell, which consists of silicone gel or water. The indications for implant use is the breast augmentation, breast reconstruction, post-mastectomy, replacement of implant with a new implant, and in cases of asymmetry correction or chest dysplasia, we use breast implants. One of the questions that we have to deal and we have to answer to the patients, and we'll try to give the answer in this presentation, if the implants have a lifespan and if they need a replacement or not. So the silicons are polymers with a different kind of chain, and the viscosity and silicone fluids are determined by the chain. So as hard as we need to be the silicone, then we change the chain of this material. So the breast implants, they're differentiated between round and shaped or anatomical implants. And also the other thing that we have to consider, if they have a smooth or texture outer shell, and the texture can be silicone with water inside, the Becker kind of tissue expanders or implant, and the polyurethane. Another thing that we have to consider, that never the anatomical implants can be smooth, otherwise they're going to rotate all the time. So the timeline of the pressed implants, there's a huge history, more than 50 years, started at the very early of 1960s, and they moved from the first to the second, and then now we are at the 6th generation of the time of the breast implants. But the whole evolution of the implants, as we can see, is a different kind of material, and not something that is a new implant, new device. From the beginning, we have a hard outer shell with a soft inner shell, and the old generation changed the quality of these kind of materials. But now the 6th generation of implants, we are talking about the more, let's say, clever devices that sometimes they have a tag on it, which would a small chip which can collect and give us information, and maybe the future of the implants can be moved to some more sophisticated devices. So the silicon density, cohesiveness is this part that gives the different shape of the implant. And nowadays, that the 6th generation of implants, we can talk about responsiveness of the devices, which, as you can see at the horizontal position, they look like a round implant, but in a vertical position, they take the anatomical shape. The majority of the implants we had in the past, we experienced big problems. And I mean, the surgeons who try to deal with the silicon seal leak or rupture of an implant was quite terrible experience. And it's almost impossible to remove all the soft silicon or the leak of the silicon into a pocket. Then that was the idea of moving to the high cohesiveness of implant or the super elastic. And nowadays we moved in the next generation of polyurethane again with the lightweight of implants. The manufacturer of doing the implants is the beginning. We have a material, and the material dips into the silicon, stays there for a few seconds, and then it depends if we need to have a texture or smooth implants. For smooth implants, we just put the implant in a laminar flow oven, and then after the heat, we have the final product. And the actual smooth implant is not smooth, entirely smooth, completely smooth. It's a super nano texture, as I could say. With, as you can see here, this is probably the best the smooth implant, the smooth surface can be. From the other side, when we need the production of the texture implant, then we have the same production again, but after we have the implant and before to go to the heat, the implant is dipped into salt, and then it depends of what kind of technology we need. We have either to wash the salt out and we have the Biofilm implants, or to brush the salt away and we have the Seroform implants. And the other kind of technology, which again, they use the kind of imprint. They use a negative contact imprint, which is from polyurethane foam. And then this is the Siltex implants. So if we need to see what kind of implants we have to differentiate them between the smooth or nano texture, the micro texture, and then the macro texture implants. And these are the implants which causes all the problems for the ALCL. And when we deal with breast implants, so we don't have to forget all the complications that may experience, but I'm not going to go through all of them, but I'm going to stay just to the BALCL, which is actually what we need to be informed about that. And this is an iatrogenic malignancy. It's a new type of cancer. It's a rare form of preventable, this is a new word which has been seen in the new publications, non-Hodgkin T-cell lymphoma, which is a CD30 positive and ALK negative. And the BACL is associated especially with the texture surface of breast implants and tissue expanders. And it is developed around breast implants, both in cosmetic and reconstructive operations. Well, the first that was reported in 1997, and for many, many years, till 2011, which we had only 34 recorded cases worldwide. We didn't even consider to inform patients about the ALCL, or we probably didn't know about the ALCL. And then within the next 8-9 years, we had 573 cases, which was confirmed worldwide, and that was reported in FDA with 33 deaths related to the ALCL. And then that was the time that FDA was the first time who recalled and suspended one of the highest volume texture implants manufacturers, or the Allergan one, which is then the company voluntarily recalled the products. The presentation and the symptoms of the disease is most of the time we have a fluid collection, diffusion, and there is an infiltration or mass. And we have to be aware about the misconception that the absence of fluid doesn't exclude the diagnosis of ALCL. The breast enlargement is the most of the time unilateral, and the onset of the disease is quite rapid. Other symptoms can be the change in breast shape, breast firmness, pain, can be a pruritic skin rashes or lesions, the deep-seated internal itching, and also the patient can see to have a fever, night sweats, fatigue, capsular contracture, and also lymphadenopathy. The time which the ALCL can be presented, the average of the presentation of the studies confirm that the presence of the BI ALCL is about 8 to 10 years after the breast implant placement. And the shortest interval time which is recorded is 2.2 years after the surgery. And the commonest area which we can see the ALCL is the periprosthetic space. And as you can see at the arrow, this is the fluid around the implant, and this is the scar tissue. This is the capsule, which is, we can see the formation of ALCL cells to be produced there. Very rare, we can see also invasion of the chest wall, bilateral disease, lymph node involvement, and metastasis. The diagnosis, if you have a history of a patient who has a breast implants, any surface, any type, and there is a delayed seroma, unilateral breast enlargements or mass, that patients require a careful evaluation. And we need to have an ultrasound on an MRI imaging. At the MRI, we can see the fluid around the implant, and then we can suspect that if it's a very fast creating swelling of the breast, then we can think about this kind of disease. But the pathological analysis of the fluid and the tissue sample is this one which is going to give us the exact diagnosis, and we need to have a CD30 positive, so the fluid and also the capsule, and to be ALK negative, as I said before. And the management of the LCL patients involve imaging for metastasis like a PET scan or CT scans, oncology consultation, and completion at the surgical excision, which means that we have to go back and take a block to do the resection, to remove of the implant, and to do a total capsulectomy, which a lot of times is quite difficult when we go to the chest wall, if there is a invasion of the disease onto the capsula, which is on the chest wall, and to try to do any tumor excision with to have a negative margins. Then we have to send everything to the pathology and to discuss with the pathologist about the findings of the surgical operation. And if there is a residual disease or invasion beyond the capsule, then we have to consider about systematic chemotherapy, targeted immunotherapy. There are also described the chest wall radiation and or stem cell transplantation. So the question which we are going to answer are, what is the difference between the smooth implant surface versus the texture? And the BACL is a disease associated to purely texture surface implants. The exact etiology is not known and is probably multifactorial. And this, if we knew that what is the etiology, probably we can answer the question if the texture or the smooth implants are associated to the disease more precisely. But today, we have not identified any cases which is registered with a smooth devices, purely smooth devices. The FDA reports 26 cases of ALCL with smooth implants, but 7 of those had the previous texture devices, and 19 patients had a known history of prior implants. Of all those 26 cases, there is a reported 1 death with smooth implant, which has the history of prior texture devices. And according to the multifactorial but unknown pathogenesis of the ALCL, probably there is a genetic predisposition still under investigation. And the bacterial, I would say, microinfection of the surface, which the theory behind that is that the increased surface, it creates a chronic inflammation, which the chronic inflammation then removes some small particles of the shell, and maybe that causes chronic irritation of the capsule that can host more easily the ALCL there. And does the surface of the breast implant increases the risk of BALCL? The surface and the studies which was done and published back on 2018 say that there is implication of the biofilm theory around the capsule formation. And as it is said, it is there is a paper which compare the different kind of materials. And here we have with the red color the biocell of the allergen, and compare with the Siltex and the polyurethane. And as you can see, the red color, we have a hugely increased number of ALCL cases between the 5th and the 12th year after the implantation, while the polyurethane was increased after the 5th year and stopped at the 8th to this study. And the blue color, the Siltex, we have again an increase after the 5th year, but not that significant as the red color, the biocell, who led actually to recall this kind of implants. About the tissue expander, the question is there a risk of ALCL? Actually, we don't have enough data to answer in this question, but because the indication for tissue expander is not for a long time, it's about 6 months, and then we have to replace the tissue expander with a permanent implant, maybe the tissue expander doesn't create a kind of ALCL manifestation. But I would say that probably this is a question that we do at the moment with all the delays we have at the COVID, and we have operated patients before 2 years in the public sector, which at the moment they cannot go for to exchange the tissue expander with a breast implant. And now we have to see and consider if there is any problem at the ALCL later on. So far, well, there is no any case reported with tissue expander and ALCL. And we have also to know that the inside cell, which be with silicone or water, this is probably an independent risk factor, which is not associated with the ALCL problem. Let's see now a little bit the countries and the national organizations, how to deal and what are the present situation. The FDA had recalled the biocell implants of the allergen back on 2019, and now 2020, the last report we have 733 cases of registered BALCL and 36 deaths, while the Australian say that the smooth implants and many microtexture implants have not been affected by the recall, and they do recommend these kind of implants. The Canadians also, like the FDA, have suspended the allergens back in 2019, and the French National Organization suggests that preferably to use smooth implants, and also, as it says here, the microtexture and the polyurethane implants are also has to be considered their use, but one of the comments that we have to state is that the committee doesn't recommend preventive explantation of the texture implants, even of these categories that have been so far been recalled. The whole European community doesn't state and doesn't give any guidelines, because we have all the national countries and national organizations in Europe, but states on and calculate probably the risk of every implant, and say that the risk of getting ALCL is 1 per 2,596 of the polyurethane, and then goes on to 1 to 3194 of the biocell, 6024 for Nagor, and 36,730 for the Siltex. So we have to consider what is the risk, and we have to provide the patient the information. And coming to the end of my talk, to have a little bit of time for conversation, is that we have to stop, as plastic surgeons, we have to stop using the recalled breast implant. We have to aware and inform the patients that they have been operated and they have a recalled implant, that there is no panic. If they have symptoms, then they have to understand early and to come back to the plastic surgeons. We have to explain to them the risk of developing BIALCL. The patients that they have ALCL must go for surgical treatment and oncology consultation. And if we suspect ALCL, then we have to collect fluid and send histopathology tissue as well. And we have to wait for CD30, which is the indicator for positive ALCL, and anaplastic lymphoma kinases negative. And if the results come positive, then we have, after the surgery, of course, to report the patient to the national organization and to the Plastic Surgical Society. So before the implantation of any implant, either for cosmetic or for aesthetic or for reconstructive surgery, we have to inform the patients about the breast implant characteristics, to ask the patients to visit the manufacturer's website to get more information and to be involved in the decision of the make, and also to discuss about complications, include the ALCL. This is something that we have to say on the consent very clearly, that patients can develop ALCL, and to be informed about what they have to do to deal with LCL. And the question, if they have to change the implants after 5 or 10 years, or if they have to change the implants, the question is answered like no recommended explantation if there are no symptoms. But we have also to know that a new implant, a new device, there is a guarantee of some years, or different companies provide different kind of years about the guarantee. Then after the guarantee, some of the patients have to go back and replace the implants. So they keep the patients have to keep the breast implant identification card, and also the surgeons to know this kind of number. And we ask the patients to yearly visit the plastic surgeon. And in cases of clinical indication, then we have to ask for echo or MRI. And in conclusion, we have to just put my thoughts that in cases of breast reconstruction, as before we said, the plastic surgeons and breast surgeons have to be in a very good communication. And in cases we discussed about if the patient is going to have a radiotherapy, then my perspective is in cases that we are going to have known radiotherapy, probably is better to go for a delay reconstruction directly. But with this point, probably we have to think about offering the options and go back to autologous tissue breast reconstruction. We have many options like a deep flap, they have a fold, or the fat lipo transfer. And in cases which we are going to consider for putting a tissue expander at the first stage, then the patient have all the time to think about the second stage. Maybe it's better to go for autologous tissue breast reconstruction. Thank you for your attention, and I'm happy to answer any question.
Thank you, Dimitris, for your informative talk. Yes, first of all, let me see if we have any questions. Yes, there's one question from the audience. If you exchange a texture implant, would you do a full capsulectomy before you insert a smooth one? Sorry, if you exchange a texture implant due to a rupture, for example, would you do a full capsulectomy? Not very related to lymphomas, but can you answer, Dimitris, please?
Yes, we have seen a lot of patients, and we try to deal with this kind of situations as much clearly as we can. And this, we try to take the full capsulectomy, of course, because if the implant is ruptured, we try to take the whole capsule without to open it, to remove it, because otherwise we have a leak of the silicone outside. It makes our life difficult. And in cases that we have a very old implants and they were ruptured, and accidentally the capsule was open or it was quite stuck to the superior wall, to the chest wall, and it was unable to remove, and we had a leak of the silicone, those cases were sometimes quite terrible, and we decided to go in it just to close without to replace the implant in this stage and go back in OR 3 or 6 months later after no having any cause of infection, any trouble of infection, and do the implantation then.
Thank you.
Can I add something?
Dr. Sanidas has raised a hand.
Yes, thank you. Excellent talk, Dr. Dionysio, because I have a case which is bothering me these days, although it's only 2 years that the patient has put her implant in, and she has a very large fusion. And I want to ask you about this CD30 immunohistochemistry. The guidelines of the NCCN of the 2019, it says that CD30 immunohistochemistry is a fundamental part of the diagnostic tests for ALCL, but is not by itself pathognomonic, because CD30 expression is non-specific, and CD30 can be expressed on benign inflammatory cells also. So if you see scattered CD30 positive lymphocytes, this does not necessarily mean that the patient can put on diagnosis of ALCL. And also about the ALK, the anaplastic lymphoma kinase, it says that ALCL is always ALK negative. However, there are other systemic and cutaneous forms of LCL are frequently ALK negative. So you mentioned with red letters that we should look for the CD30 positive and ALK negative, but as we see here that by themselves these indicators cannot put by themselves the diagnosis. Just a small comment if there is.
Yeah, I mean, my comment would be that at the moment the guidelines stay on that and say that if there is to place the diagnosis of ALCL, these are the two indicators. And of course, you have to see the clinically. So if you have the symptoms which mentioned before, and you have a CD30 and ALK negative, probably I would treat this patient as a ALCL patient. I don't know if something else would later be produced, or maybe the genetic profile, maybe something different. But at the moment, I would say that it's better to stay at the rules.
Yeah. Okay. Thank you very much. Thank you.
Hello. Can I ask something, or you think it's too late?
Of course, you can.
Yeah, I think this is it's mainly a question, comment as well. I would like to see some opinions, because it's really something that is in my mind all this time. And because I'm very much involved in breast augmentation and the exchange of implants, reaugmentation cases, and capsular contractions, it's very difficult to answer, in fact, how you should manage a patient with a capsular contraction. Dr. Dionysio said very well that it's not only seroma, so it can be just capsular contraction. So when you see a patient with a high degree of capsular contraction that needs capsulectomy, and replacement of implants, what do you really do? Plus, Dr. Denisio said that we manage this patient as a potential Lcl patient. I'm really puzzled when we say about 100% capsulectomy. This is, in several meetings I've been attended recently. What is really 100% capsulectomy? First of all, it has a 3% of pneumothorax as a complication as far as I'm concerned. And how easy is to really achieve 100% capsulectomy? So these are thoughts that I like to share with you. And sometimes I'm puzzled, how should I manage a patient like this? And how should I approach them even in the consultation room? For example, a patient with Allergan implants who had several years ago, it presents in the consultation room with a high degree of capsular contraction without seroma. What do you do? And she wants to treat the capsule, and she wants to replace the implants. What do? You take him for a 100% total capsulectomy. And this is a question that is really addressed to the panel, because as far as I'm concerned, that I know, for example, in England, some of the plastic surgeons, like David Floyd, he's very expert on that. I heard some of his talks. He says that the incision for the total capsulectomy is nearly the whole inframammary fold. So it's not so easy to say that we perform a total capsulectomy. So how do we manage a patient that comes back to us after a reconstructive case, or even after a prosthetic augmentation case? It comes back to us with a high degree of capsular contraction without seroma. Because if there is a seroma, at least we can, you can take some of the fluid for a cytological examination. But how do you manage a patient like this? I'm really puzzled these days. I would really like to hear some, some comments from the panel, if possible, please.
Any answers from the plastic surgeons, Dimitris?
Yeah, I mean, I can start trying to give some answers, and then happy to answer to hear everybody. I mean, too many questions as we have to deal with, and it's not. I didn't say that I would do that one. This is the guidelines that we have to follow. And when they talk about total capsulectomy, I think everybody understands that it's nearly impossible to try to do total capsulectomy, because when we go to the chest wall, sometimes, as you said, there is a possibility of pneumothorax. And but as they said, you can see the invasion sometimes on some lesions, and then you have to take them out. And these invasion of the lesions can be the Lcl cases. In cases of capsular contracture alone, without any seroma inside, if the patient had an Allergan implant which is suspended now, I would probably consider of taking the implant out, taking as much of the capsule out, and replace the implant with a new implant. Again, what is the symptoms? We have to be on the mind. But the majority of the time, we have a seroma, we have a fluid collection, not seroma, fluid collection there, this is the majority of the ALCL cases. The rare situations are when we don't have any fluid collection. As you said before, then when we have a fluid collection, then we can aspirate with an echo, with an ultrasound, and we can send some fluid to pathology.
Thank you, Dimitris. Do we have time to go on with this, or should we call it a day? I think unless there's a question, a burning question, there are always questions.
Michael, I would be happy to listen to someone else too. I mean, Dimitris, if there is a time, of course. Dimitris Adonopoulos.
Dimitris, you have, sorry to say that you have 30 seconds because we are way beyond the end.
Okay. One quick question to Dimitris and all the other plastic surgeons from Greece. Is there any case in Greece noted as BALCL?
No, it's not reported in Greece in case.
Okay, second thing, I think about the capsulectomy and capsulotomy, Tsakouras talk about two different ways. It's different when we do the capsulectomy in aesthetic surgery than in reconstructive surgery. The first thing is when we proceed to change the implant, I think we should send a piece of the capsule for pathology investigation, and we have to do it. We have to do it. Another thing, we can do a complete capsulectomy when we infiltrate on the posterior wall of the capsule with a normal saline with a little bit of the adrenaline inside, and to avoid any problem with pneumothorax and other problems with complete capsulectomy. This is my comment.
Thank you, Dimitri. If we all agree, there's one more question. One case of lymphoma from Greece was reported to FDA as of now. Thanks. This is from our fellow plastic surgeon, Dimitri Mastorakos. So we have one case of lymphoma.
Yeah, I know about this case, but is it clear? This is my question. There is a little bit to investigate about this case.
Okay.
Anyway.
So we may have one case or not, but a small number of cases. Reaching to the end of this webinar, Dimitri Dionysiou, thank you very much for your talk. As always, to the point, very informative. You managed to scare us once more about this anaplastic-led lymphoma, but we promise you we'll keep on using implants, and patients will go on benefiting from it, because implant-based reconstruction has a part. In Greece, at least, it is the vast majority of reconstructions are done with implants, if I'm not wrong. I would like to thank all the participants in this webinar. Up to now, we have about just under 200 participants attending. It was a long journey from 10 o'clock Greek time to now. Myself, I learned a lot of things. We heard experts from the Greece and from the UK, from abroad. Taking you very quickly through what was said today, we started with the basics with the principles of oncoplastic breast surgery with Mr. Daniel Lev. Going on to George Metaxas, who introduced us to the basics, to the simpler oncoplastic procedures, like all the lateral mammoplasties, the round blocks, and the L and J mammoplasty, and the problems they may have. Then Mr. Hadjiminas showed us his video about the LICAP flap. And at least in my eyes, he managed to make it simple. This is the ability of an experienced surgeon. And then Mr. John Murphy from Manchester talked to us about the problems and the tricks and tips of all the other local perforator flaps. Nikos Michalopoulos talked about the extreme oncoplastic breast preservation, and compared these big resections with mastectomies. And our friend Yazan Masanat talked about whether it is worth trying a breast conservation in multifocal or multicentric cases. James Harvey said a few things about skin-reducing mastectomy with or without nipple reconstruction. And then Dimitris Andonopoulos very quickly talked about whether we should use and in what case we should use direct to implant or use an tissue expander. Tasos Tsekuras later in the last session took us through the travel of choice between round or anatomical shaped implants or to mesh or not to mesh. And Giorgio Berna talked about the prepectoral reconstruction and how we should use the regenerative implants, which help the tissue to grow on the mesh. Theo Nanidis and Vicky Harmer talked to us about the nipple reconstruction and tattooing, medical tattooing of the nipple. And finally, Dimitris Ioannisiou said a few things about the anaplastic large cell lymphoma. And I think this concludes today's webinar. There are a few more comments on the Q&A, and congratulations from the audience. Thank you. And I will give the floor to Mr. Venizelos, the President and Chairman of the Greek Society of the Hellenic Society of Breast Surgeons, for closure.
Thank you, Michael. Well, this was an excellent webinar. Thank you, everybody, for excellent presentations. And on behalf of all the participants, the 200 participants of this webinar, I would like to thank the two presidents of this webinar, Professor Kondos and Dr. Lamidis. This was an excellent job, guys. Thank you very much. And Sophocles, unfortunately, he's off the internet, and he sent to everybody his regards. And again, from everybody, congratulations to you guys. I hope to see you next Saturday for the next webinar of the Hellenic Society of Breast Surgeons. Again, thanks a lot.
Bye. Thanks a lot. Thank you, Vasilis.
Bye-bye.